Support for this podcast and the following message come from Amgen, a biotechnology pioneer fighting the world's toughest diseases, such as cancer, heart disease, asthma, and osteoporosis. In a new era of human health, Amgen continues to accelerate the pace of change, operating sustainably and drawing upon deep knowledge of science to push beyond what's known today. Learn more at amgen.com.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Julie Woodward. Dr. Woodward is an oculoplastic and orbital surgeon at Duke University and a national expert on facial aesthetics and rejuvenation. Dr. Woodward, thank you for joining me tonight.
Thank you, Dr. Ball, for having me again. I'm really excited to do the Pupil Pod again.
I know, and we're excited to have you. We had so much fun the first time. Just jumping right into our case. And this is a really interesting conversation that we're going to have today because it's not our usual case, but it's something that is more and more important as we go into the year 2025 and beyond. So we have a 62-year-old woman who presents to clinic stating that she looks tired all the time and wants to discuss options to look more refreshed. On exam, she has mild dermatochalasis, periorbital rhytids, mid-face volume loss, and subtle jowling. Now, Dr. Woodward, I know this is a big topic. We kind of talked about this before the podcast began. There's a lot to cover here. How would you instruct residents to approach a patient like this? How should they have those conversations? What should they think about?
Well, this is a great case being a 62-year-old woman because this is the bread and butter of my practice. This is exactly the kind of patient I like to see. They're not too mature. They're sort of new. They're wanting to just get their feet wet with a few ideas of minor things that they could do. And then we'll kind of roll them into surgical options later. So my favorite way to approach these patients is, of course, I come in and I introduce myself. And I want to know two things right off the bat. I want to know who referred them so I can send a thank you letter. It's always important to send a thank you. And I ask them what they do just to help get to know them a little bit. And I always document that right in the chart. So when I see them in the future, I have a vibe for who they are and what their career is. And then I start asking them what they want to do, what bothers them about their face. Because some patients will want me to pick out issues that I would like to work on, but I always try to see what they're interested in. And then I always ask them permission to take photos. I always say, is it okay if I take some photos? And once I have the photos, that's really key because then I flip the camera around. It's just a small camera. I don't have them uploaded yet. I say, let's go over your photos together so they can see what I'm looking at. And then I immediately start talking about their anatomy. And I start from the outside or for the inside and go out. So I start with the bones. I talk about some asymmetries. Let them rest assured that asymmetries are normal. We're not ordering CT scans or MRIs. Most patients are not used to seeing the asymmetries in their face because they see themselves in the mirror every day. And when you flip it around and give them a mugshot of themselves, they're like, oh, what's that? So we go over subtle asymmetry and they're usually surprised. And the most common thing they always say is, why is that? And it's like, well, that's just normal. So we talk about asymmetries of the eye, not just which brow is higher or lower, but which eyeball sits higher or lower, which orbit is bigger or smaller, and which eye may be slightly more proptotic or anophthalmic. And then once I understand some of these things and understand that I'm paying attention to details, then we roll into some ideas of what they could do.
You know, I love that concept of starting from the inside out. I haven't heard that before, but I think it really grounds the patient in the fact that you are really taking the time to pay attention to the details, like you mentioned, and see what they are kind of wanting you to see. So when they ask you, like, what do you see? You're telling them from the inside out. I really, really love that. That's amazing. So, based on that, what are the major categories of non-surgical treatment options that you can consider for a patient like this one? And then we'll kind of talk about the surgical options that you might consider.
So, of course, we're all familiar with non-invasive things such as injectables, such as neuromodulators, and we go through different options such as Botox, Dysport, Xeomin, Jeuveau, and Daxxify that we talked about on our other podcast. And then when it comes to dermal fillers or facial fillers, It's mind-blowing how much there is, and we should actually just do a whole podcast about that. I always tell the patients, I've got about 15 or 16 of them over in my cabinet there, and I don't even have all the ones that are FDA approved in the United States, and they all have their niche. The amazing thing about the patients is they don't know where to start. So they're really looking at you and putting their trust in you to make the best recommendations for them. So it's really important to understand the rheology and the anatomy to get the best results for your patients. So we'll talk a little bit about those injectable type options. And then there's this whole world of biostimulators, which are polylactic acid and calcium hydroxylapatite and some of the regenerative medicine that is so hot right now. Patients are becoming a little bit afraid of some of the fillers. They're hearing negative things about, and so they're interested in what kind of regenerative options. And sometimes they're not good options for the patients, but it's important to be well versed in all these different things so you can come up with a journey, a plan for the patient to feel comfortable with how invasive you're going to be and what their budget is as you kind of lay out this groundwork. And then you have to also introduce non-invasive devices such as, lasers. You can do intense pulse lights, broadband lights, ultrasounds, radio frequency, microblading, as well as microneedling. And it's just a huge world. And the regenerative medicine is really exploding. That's exosomes, secretomes, hybrisomes, pyrosomes. There's all these things on the market that are really growing in popularity. And you really have to sort of narrow it down and figure out what your patient's comfortable with starting.
It was already overwhelming as someone who doesn't practice really much facial rejuvenation, for my patients. For myself, absolutely, I'm on board and I want it all. But, can you break down kind of just broad strokes, obviously, but what areas you would treat more with neuromodulators versus fillers and kind of how you distinguish which would go where?
Yeah, I figure out which wrinkles bother the patient the most. Are they really concerned about their number 11 or their crow's feet or the nasolabial folds? That seems to be the most popular areas, infraorbital hollows. And then I describe their rhytids to them as having mountains and valleys. Neuromodulators softens the mountains so they're not so elevated. And then fillers fill the valleys. So, and they have to understand that one is softening the way muscles react, it's really acting on the nerves. And then the fillers are plumpers. So they have to understand the difference. A lot of them have absolutely no clue. And then you have to talk about the biostimulators to stimulate. Some of them want a green treatment. They don't want something, they're afraid of poison or other things that aren't really rational, but that's their mentality. And so you want to be able to talk to them about the biostimulators that stimulate the collagen to be grown in their own skin. I love that. I just had Sculptor a week and a half ago. I still have a little tiny bit of bruising, but I'm so excited and I can talk to my patients about what I've done to my own face and they love it. And then for fillers, most patients want to try some kind of filler as well as a neuromodulator. Those are the two basic things to get started with. So talk to them about nasolabial folds, marionette lines, melolabial folds. The malar hollows, that's huge. You don't want to inject a nasolabial fold without giving a little counterbalance in the malar area. Cheek lines, etched lines, chins, jaw lines, temples. These things are all FDA approved areas or indications for these fillers. And you have to see what would be the best bang for their buck because a lot of them may be limited on their budget. So you want to get them a result that they can actually see something. And then if they have more downtime, that's when you start talking about lasers or broadband light and other things. And then ask them if they have dry eyes. If you're a cornea specialist like you may want to have, an OptiLight in your office or, a Cyton broadband light. And you can say, hey, we can make your skin tone look better at the same time be treating your dry eyes. And that could be really exciting for them. So it's really important to just kind of figure out the areas of their face that bother them the most and kind of figure out their plan for those areas and then broaden it from there.
I love that, and I love the dual action of dry eye and facial rejuvenation. So when you're counseling these patients, what are some of the complications that you talk about? I know you said bruising. I've had bruising before, even just from Botox on my face. I've had bruising. Sometimes it happens. But we've been hearing these horror stories lately of filler migrating or filler staying in the face forever. How do you counsel patients on that? What is the real risk of that? Have we hyped it up to a point where that's not a reality, where we overfilling faces, giving them that pillow face, and that's why it's migrating?
First of all, the first thing I think patients are concerned with is allergy. They're afraid they're going to be allergic to Botox. They're afraid they're going to be allergic to the filler. So you can always assure them that allergy to a toxin is exceedingly, exceedingly rare. And the few cases that have been quote reported are usually really something else. Fillers, you can tell them that Fillers are already in your body. They're hyaluronic acid. They fill your eyeballs up with their jelly and your knee joints with their synovial fluid. They're so safe that the FDA does not require patch testing. Not to say there can't be delayed type hypersensitivity reactions, and that is mostly what people are seeing on the internet. 2 to 4 months after someone's injected with filler, if they do something that revs up their immune system, such as a bad sinus infection, I've seen it with a urinary tract infection, a cut to the skin, the filler can flare up. It usually goes away with a little bit of Benadryl, some steroids, maybe some doxycycline. Now, biofilms are bad complications where bacteria get stuck in a biofilm, and those are much more difficult to treat, but they are exceedingly rare, as are granulomas. So their fears of some of these products are not without valid concern, but they're rare. And I think if you take really good care of your patients and do excessive amount of cleaning, those complications are exceedingly rare. So I think you can have them rest assured about that. Now, as far as the migration happens when patients do get overfilled. There's only so much you can cram in lips before it starts migrating up their lip and they start to look like Marge Simpson. And filler temple can find a pathway and sink underneath the zygoma and end up in the mid cheek. But migration under the eyes, it happens. It's more just that it does get locked in. And we've known for years that filler lasts 10 to 15 years. That is nothing new. We actually viewed it as a good thing. It's just that some injectors keep pumping it in there and pumping it in there. And the patient comes back and says, I think if I pay more money, I'll look better. So somebody puts more in their face and then they become overhydrated. And that's when it's time to counsel the patient. Hey, we need to dissolve this, tighten you up with a laser. It's a little bit of a journey on its own to kind of refresh them, but it's always treatable. That's the great thing about hyaluronic acid fillers compared to some other things, such as fat. Fat you have to cut out. It can be a nightmare, and other things that that are permanent fillers in silicone and the other semi-permanent fillers that you just can't get rid of. They go to the grave with you, basically.
What about vascular occlusion? There's a lot of discussion, especially in ophthalmology, about the risk of vascular occlusion, especially for injecting the tear trough. What is the actual risk of that? I know it's very, very low and very rare. How worried should injectors be? How worried should ophthalmologists be about their patients who are maybe getting under eye filler?
Actually, the risk of a vascular occlusion in the infraorbital hollow is almost zero. There's about 6 or 7 cases reported in the literature. There's no vasculature along the infraorbital rim that could really connect to the eye. So I teach a lot of anatomy classes. I've taught anatomy for Allergan, Galderma, MERS, Prolenium, and a lot of independent classes. I'm teaching a big one this summer out in Los Angeles. I think it's August 15th or 16th. So if any of you residents want to come and learn injection anatomy, which is so different than other kinds of anatomy that you might learn about, please come to that cadaver course. There's nothing like a good cadaver course. But that being said, I teach residents and whoever's learning to inject, there's 9 danger zones around the eye, and I go in a clockwise fashion to show people where these danger zones are. And you just have to be aware of the direction of the vessels. I personally have never had a vascular occlusion. I think if you're constantly daydreaming about what the anatomy is beneath the surface of the skin, the chances of getting into a vessel and putting enough filler there to cause a problem are exceedingly low. There's task force that I'm on, and I've been on all kinds of safety panels for industry and for non-industry, talking about how to manage these vascular occlusions, and particularly the ones that can go to the eye. I published papers on anatomical roots of how it gets to the eye. And I think it's just really being cautious using small aliquots and understanding the direction of the vessels. I try to go perpendicular to the vessel instead of the same direction as different vessels. And I think you can inject safely. You're never 100% risk-free, but you can really, I mean, like I said, I've been injecting for a really long time. I don't even want to say how long, but I've never had an occlusion. And I think if you're careful, you won't. But that being said, I really wanted to talk a little bit about residents getting access to training. One thing about extenders or nurses or PAs that want to learn how to inject, the second they finish their schooling, industry pounces on them and says, hey, let's take you to our training course. You'll be trained. You'll be a certified injector in 1 weekend. Most of them have never attended a cadaver course. The average course I teach, I ask the audience, how many of you have actually taken a cadaver course? And it's usually about 40%. So, and we as physicians are often expected to be training and supervising these injectors. So I think it's really important to get your hands on. The problem is residency programs are very anti-industry, so it's very difficult. They won't let industry in to help teach you. And the residency programs themselves may not have the money for cadavers or the resources or the faculty to be able to teach these things. So you need to be aggressive and reach out to industry on your own. They have programs that you can sign up for. Well, they will actually even fly you to some of these places to get trained. They will donate product, but that doesn't help if you don't have a really good teacher. You need more than just a pile of toxin and a box full of fillers. You need to have a really good person help you with your hands on, and that requires a lot of time. And I think if you're just an aggressive resident that wants to learn how to do these things, you can seek that training out through industry.
That is so important. I'm so glad that you discussed this because we get some basic training during our residencies, but for example, I just started doing Botox this year for hemifacial spasm, blepharospasm, so for functional issues. But of course, my patients, no matter how old they are, they can be 85 years old. They're telling me, well, when I've been getting my Botox injections for the last 10 years, my face doesn't look symmetric. Can you help me make my face look more symmetric? And I would love to, but when you don't have the training, it's not just, I mean, it's very easy to inject. When you're a surgeon, you can actually do the act of injection, but it's the art of facial symmetry that is a lot more difficult to master. And I think having that cadaver anatomy course could really help residents, especially those who are going into this field where they know they're doing a lot of facial rejuvenation, to understand better the anatomy and also how to prevent complications, how to make your patients happy. I mean, that's such an incredible opportunity for people. So definitely something I'll even look into in the future, I think.
Well, I hope everybody comes to that cadaver course. And as far the other part that you can learn at these courses is patient assessment. It's not just a strict rubric. Some people I train, I notice they want to know, well, if I draw a line from here to here and it crosses with this, bing, that's where I'm supposed to put my needle. But it's really not like that. It's very artistic. And when I assess my patients, I always go very systematic. I start at the hairline. I talk about their hairline, their forehead rhytids. They may be a little crooked one way or the other. I talk about the brow, and I come all the way down to their chin. And I think patients really appreciate that full face assessment before you start recommending products and actual treatments.
Absolutely, absolutely. Okay, so let's say that this patient has tried the neuromodulators, has tried filler, but she's interested now in longer lasting results, or she wants something that is a little bit more dramatic. What are some common surgical procedures? How do you talk to patients about these? How do you decide who's a good surgical candidate?
Yeah, well, of course, our bread and butter is blepharoplasty, and I love doing my blepharoplasties with the CO2 laser. It's a beautiful magic wand of light that makes these beautiful light incisions. But they may need more than blepharoplasty. You know, they may need a brow lift. I do a lot of unilateral brow lifts to improve symmetry. Patients really appreciate that nuance. We actually did one today. And a lot of times I'll do fat transfer around the eye. So most patients have prolapsed nasal fat pad, and we'll take that fat pad and move it into what we call the A-frame deformity, because we tend to get a little hollowness over our supraorbital notch as we age, and that makes a much more youthful contour. So blepharoplasty, I never say it's an eyelid operation. It's a operation of the orbit. I don't think it should be belittled. I really think that we are orbit surgeons when we're doing blepharoplasty because we're past the septum and into the fat. So I'll transfer the fat in the upper lids, and then coming down, we do lower lid blepharoplasty, usually transconjunctival. And in patients that are really good candidates, we'll take their nasal and central fat pads and spill it over the orbital rim and suture it into place to help fill the infraorbital hollow. For me, a really good candidate is someone with a very full cheek and a very big hollow. I won't do it on people with mild hollows. I think that filler is a little bit more manageable. And then we'll always do laser resurfacing around the eyes. I don't do very many transcutaneous blepharoplasties unless they have a large festoon where we're doing a muscle flap, an orbicularis muscle flap. So that way my surgery doesn't change the shape of the eye. One of patients' fears is they're going to get a transcutaneous bleph that their friend had, and she looks older because the canthi is pulled down. They have a very slight ectropion that usually takes 5 to 10 years to develop after that skin is removed. You may not see it right away, or when that little transition zone's been cut out, the surgeon ends up suturing a little bit thicker skin from below the tarsal plate closer to the lash line, and it just always looks like a very slight bulge under the eyelashes. So I really prefer the transconjunctival approach, and I think most oculoplastic surgeons do.
Absolutely. That's the main approach that I think I trained on in residency, and it's so great that we have we have that option available to our patients. Now, you did mention some recent advances. We talked about regenerative medicine, we talked about fat grafting. What are some of the techniques that you think residents should know about? What are some things that you're excited about and you want the younger generation to know is out there?
Well, I think what's really on the horizon that's getting all the hype now is regenerative medicine. It is I didn't really understand it at first. I mean, PRP has been around for a while, and PRF, which is platelet-rich fibrins, those things have been around for a while. Kind of quasi how much they really fill. They're a little bit better for skin quality. But the big controversy is the regenerative medicine that's in exosomes and secretomes. I'm running a meeting in June with a dermatologist named Shino Bay. Some of you may have discovered him on your Instagram. He's very Insta famous and brilliant. And so we're running a Genesis meeting also with Doris Day, who's a dermatologist in Manhattan. And the Genesis meeting is really to bring a lot of the regenerative medicine to the United States because there's so much more of it going on overseas. And it's very controversial because it oftentimes comes from human sources. So it comes from I was mind blown when I saw how many sources it comes from. It can come from plasma. There's one company that goes around and scavenges up plasma from blood banks. It takes the exosomes off of that, and then it's in injectable form, and it can be a topical skin cosmeceutical. And then there's secretomes that come from a blastocyst that was donated by a couple that went through in vitro 30 years ago. Then there's products made from Wharton's jelly, from umbilical cords. There's a lot of fat-derived exosomes that come from mesenchymal stem cells from fat. There's exosomes that come from plant material, from rose hips. It's mind-blowing how many different things. There's bovine sources, and every company feels like they have their niche, and they're telling you to microneedle it in, or the problem is it's illegal. It's against the law to inject it so far. Unless you're doing a research study that's approved by the NIH. So that world's really exciting, and it's definitely the wave right now. And a lot of people are mixing these things with fat as they do fat grafting.
It's incredible. I'm really excited to see what the future holds for this. I mean, just thinking back to my youth when we didn't even have Botox. We didn't have Botox. And my parents would tell me, stop frowning. You're gonna have wrinkles. And now I'm like, I don't think so. We're not having those. So it's exciting to hear about regenerative medicine. Thank you so much for joining us on this episode of Pupil Pod. I'm looking forward to hearing more from you.
Thank you so much for having me. I would love to do another episode. Anything I could do to help with resident education, and perhaps we can do one on how to get residents more involved with learning these techniques.
Absolutely. I know that there's going to be a lot of enthusiasm around that. So thank you. And thank you to those tuning in. See you next time on the Pupil Pod.